Good afternoon, everybody.
Good afternoon.
My name is Mark Johnson, and on behalf of the Howard University College of Medicine, I welcome you all here for this auspicious event. And so you say, well, why is it auspicious? Well, all the students know it's auspicious because you get a lot of money.
Right.
So now that we've made that clear, in 1975, when I entered medical school, I didn't know what NMF was. But my advisor gave me some forms to fill out and said, fill these out. Most people who fill these out get money. And I filled them out and I got money. So that makes me an NMF alumni, of which I am proud and of which I am a contributor. Since then, NMF has expanded to a lot of other things. But before I say what happened after that, you need to know what happened before that. Because NMF actually got started in 1946, if I'm not mistaken.
You are not.
In Chicago. And a gentleman recognized the need to educate more African American students to be physicians because there was a great need in our communities. So the legacy of NMF goes back that far. At first, the major, I need to tell you one other thing. In 1975, when I started medical school, my tuition was $1,250. I'm sorry, I just had to rub that in.
About a day of school right now.
Right.
An hour.
So NMF has been committed to providing financial assistance to underrepresented minorities going to medical school ever since then. Additionally, they've expanded their programming to other areas that promote leadership, promote community engagement, etc. And that brings us to where we are today. Here for the NMF Aetna Primary Care Fellows. All of you who have been chosen, congratulations.
Thank you.
You should know that I read all of your applications. I know your CVs. I read your letters of recommendation, so I feel like I know you. But I can also say that all of you are deserving. And so I think we need to thank our NMF host here today, as well as Aetna and other sponsors for giving us this opportunity. You will have experiences that will allow you to broaden your educational learning in a way that goes beyond what you get in medical school. And I hope that you will be able to carry that forward in a meaningful way into your career and your future. So on behalf of Howard and on behalf of me being a NMF alumni, welcome. Thank you.
Thank you so much, Dr. Johnson. We, as president of National Medical Fellowships, we are proud of all of our alumni, as we will be proud of you as you go through your journey from medical school to residency to becoming leaders in the field. And since we began in 1946, we've awarded over 30,000 scholarships. And of that number, we can currently find and identify addresses, affiliations for more than 17,000. And one of the things that we are now actively doing as we begin to give our scholarships is to try to be in touch with you throughout your careers and introduce you to outstanding alumni, like the gentleman sitting next to me, so that as you go, you become part of this very great community. Of the alumni that we have, about 56% are African American, 27% are Latino, and then we have Asian Americans, Native Americans, and a small percentage of first generation involved in our program for the Primary Care Leadership Program funded by GE. This is an exciting new program. I want to thank our advisory committee, and especially a lady you're going to hear from later. It has been an interesting opportunity to be here in DC and to try to achieve the goals of our funder. So the president of the Aetna Foundation is also an NMF alum, Dr. Garth Graham. And his vision for this program was that you would be introduced to the intersection of health policy, leadership, and technology. And so you are being placed with some outstanding institutions, and we want to thank those that are here today, to kind of look at projects that actually achieve the goals. I think you can change the slide. I think, Mark really, sorry, Dr. Johnson, really, spoke eloquently about NMF. The one thing I do want to say, and before I leave the history, is we have been leaders in what is now called diversity long before diversity was any part of our lexicon. We were founded so that people would get access to better health care because they would have providers who understood their communities, their cultures, and their languages. And that is still what we're doing today. 7 of you are here today. There will be 11 fellows. And I would like to take a minute to just go around the room and let you introduce yourself. And we especially want to thank our Program Advisory Committee for all their work, chaired by Dr. Johnson, and certainly thank you so much, Kathy, for everything. We have 2 guest speakers, and Jeanette, do we have? Okay. Our first.
Oh, sorry.
Yeah, it's okay.
You want to let him go first since he has to leave?
He's not speaking.
No.
Oh, he's not. Okay. All right, sorry.
Because I can do introductions if you want.
That would be great.
Okay. First of all, it's great to finally put faces to all the paper and all the reading of all your applications. And I laughed because I was waiting to see whether LaToya was going to be placed with LaToya Thomas at ATA, and that didn't happen. So. But we could have had a LaToya with LaToya in this mix. So anyway, I would like to introduce Arno Simmons, my colleague at the Health Information Management Systems Society, Healthcare Systems Society. He and I both have been committed to the work for health IT for the underserved for a number of years. When I came on board the collaborative, the Health IT Collaborative for the Underserved was just forming. And the piece that I was responsible for was under the rubrics of my previous employment, and that was the Association of Clinicians for the Underserved, for which I was executive director. And we really looked at the workforce piece and actually worked with Dr. Graham and others to really talk about the health IT workforce, where was it coming from, how was it getting trained, and all that. So I have a long history in that. In 2002, I was a fellow, a primary care health policy fellow in the federal government, and I was asked to join a group that was called the IT Working Group. Health didn't have its identity at that point. And I wrote the part of the policy paper that was presented to the Secretary of HHS that said if we didn't work on dollars and training for our community and migrant health center system and other health resources and services administration programs, we would continue to see a digital divide. And a couple years after that, the Office of the National Coordinator was established. So my little group of 5 clinicians, we thought we were very impactful, that we had really had a voice in forming something in Washington. But we also, if you look at the paper that we wrote, there are many elements of it that are still true today. And so we're going to talk, between Arno and myself, talking about one organization's approach to looking at what are the policy issues around health information technology. And since we only have a short period of time, I'd like to lay out in the packet I gave you some of the resources that I hope that you will utilize as you form your projects, but also inform your learning. There's a lot that's happened since 2002 in health information technology and the issues of the underserved. And today we're just going to give you broad brush overviews of the primary areas that an organization such as HIMSS is addressing from a policy perspective, but also from a program perspective. I'll talk to you a little bit about what I think is happening in the Community Migrant Health Center system, but also what I'm hoping within those of you in the Office of the National Coordinator will be looking at and learning, and some of those resources are in the packet for you to learn a little bit more. So with that, I'll introduce Arno Simmons, who is our Manager of Public Policy Initiatives. He has been looking at disparity issues for more years. He and I, we laugh, we're the sort of senior members of the Institute now, because so many people have come and gone, and Arno and I are still devoted to this. But he will talk to you about what the HIMSS organization is, and then why I hope, and in the packet I've given you, is a membership organization. There is a large physician interest group within HIMSS. We have an opportunity for many of the health professionals that we introduce, health policy and health IT, to become part of that physician community and interface. And by the time I finish talking, I'll tell you why the physicians need to have a voice if you haven't already learned from your sites the concerns and challenges that the physician community and other clinicians are facing. So with that, I'll turn it over to Arno.
Well, thank you for the opportunity to be here, and I'm sure HIMSS is grateful for the exposure. What is HIMSS? It's as Kathy mentioned, it's the Healthcare Information and Management System Society. We have over 52,000 individual members and about 600 corporate members and about 250 organizational affiliates. And through that membership, we have physicians, payers, a whole gamut of array of healthcare providers and so forth. And we and through those members, we form committees and roundtables, and that's how we sort of bring together the minds in the field and develop our content. And so HIMSS has been around since 1961, and it has grown to a global organization. We have offices in Asia and Europe, and also our main office is in Chicago. And speaking of Chicago, it's where we're going to have our big annual conference, where we do a lot of technology demo on interoperability and so forth. And it's on average we have about 38 to 40,000 people attend the conference every year. So yes, that's
Where do you ever hold it?
well, it's
Orlando,
only
Chicago, Las Vegas.
very
it's
few
very limited.
cities. Very few cities can hold it, and it's an awesome conference, and it's a lot of educational opportunities on health IT, and one of the great things is that we have good relationships with the Office of the National Coordinator and CMS and all of the federal organization and
CMS
members
means
of
what? Excuse me?
Center for Medicare and Medicaid.
I hope you all have
Medicaid and
notebooks for
Medicare,
acronyms,
yeah.
for those of you who don't
Yeah.
know. And actually, one of the things I will send to Jeanette is, and I didn't print it off because it's always changing, I will send you a file of common acronyms used in the IT space, because it's going to overwhelm you all. Okay. It's one of the few things I didn't print off I was just going to talk about in case you had already done that.
Yes,
But
and
all our
please feel
interns are
free
overwhelmed.
to stop me and ask me if I use them again, because it's something I constantly do. So anyhow, again, in that conference, it's and then we have members of Congress, which is something I do regularly. I do a lot of outreach to Congress, and we are not a lobbying organization. Our main goal is to educate members of Congress about certain issues in the health IT world. One of the main things that we're focused on right now is telehealth, and I'm very familiar with ATA and LaToya and Gary Capistran and the folks at ATA. And at this moment, actually earlier today, the senior director and from many organizations, from our organization and other organizations, collaborated together, and they were on the Senate side actually talking about telehealth and packaging a sort of a super bill to address some of the issues like licensure, credentialing, and reimbursement. So that's some of the things I do. The other big issue that we'll be focusing on this year is cybersecurity. I know most of you are probably familiar with the Sony hack, but there's also was hacking a hack that took place last year, mid last year, at a Tennessee-based healthcare system, and a lot of about 40 million patients' records were exposed, and so cybersecurity is something on the radar that we have to be concerned about. So we are one of the bills in Congress, and it did not, unfortunately, make it through the 113th Congress, and we're looking forward for it to be reintroduced in the 114th Congress's CISA, it's a Cybersecurity Information Sharing Act, and that bill was sponsored by Dianne Feinstein, and hopefully that bill will be reintroduced in this Congress, and I think it has bipartisan support, but I'm not sure why it did not pass in the 113th. But we're continue to talk with the Senator Feinstein office and other offices to see if that bill will make it through Congress in this time around. What that bill does is it encourage it provides money for the infrastructure and security, and also information sharing, and so that's why that bill is important to the HIMSS community. And so those are the two things. Those are the high-level overviews that I want to, and I'll just stop there, and I'll turn it back over to you.
Okay, thank you.
Yeah.
And just, we keep referring to LaToya Thomas, but she actually was staff for the National Health IT Collaborative for the Underserved, and created the website and a lot of the things that are still up and visible for it. So you'll be very fortunate to be working with her. One of the things I wanted to do, since I manage internship program for the Institute for eHealth Policy, and I have students come in public health and medicine, social work, is to really get a baseline as to how each one of you, when you've told people you're going to be in this program, what do you tell people health IT is? So I guess I'll start over here before I go through my packet. Tell me, because some of you were very open and discussed in your applications, other it was implied or inferred. So I thought, it's not something that everybody in the health professions has exposure to. I certainly didn't. My background's in public health and in nutrition, so I had to learn all of it. So let's start here. If someone were to say to you, what do you mean you're going to work in health IT? What is health IT?
Broad scope. Health IT is efficiency and safety, I would say. At least from, I try to understand where EMR's place is in the patient's life. And I mean, from working in the hospital, I've learned that safety is at risk, and patients, medical records are really important to their care, at that point in time. And then also, if you want to make sure that we're not wasting both the patient's money, whoever, or insurance company's money, taxpayer dollars. You want to make sure that things aren't being done, irresponsibly or repetitively. And I think health IT is kind of streamlining all of those things.
Perfect. Okay, and each one of you had different touch points, and I was hoping that's what would happen. Because in your folder, I tried to give you some resources to expand on the little bits and some of the words. So I thought in the time that I have left, I want to go through the packet so that you actually have some resources. But I also have a giveaway. You actually was the only one that brought up smartphone. So it is a whole field called mHealth, mobile technology. And so I can give you a whole book on that. So you won the book, and this is hot off the 2014 publication.
Awesome.
But mobile health technology, when we say health information technology, it really is the opportunity to transform the healthcare system using the tools of technology, of which the EMR, I've learned, over the years I've been involved, is just one small aspect now. The mobile technology, the smartphone technology, the monitoring devices, all the things that go on in home health, and that may be an organization there are home health agencies that are doing a lot of things with technology. But all of those comprise the umbrella of what is health information technology. But the other aspect of it is, and there's a group that we've had functioning in Washington for the last 5 years. Are we talking about health information technology or health information management, or do they now come under the same umbrella? Each one of you will be dealing with health information. Each one of you will be dealing with some type of technology or some policies related to technology. Many of us now see those as being intertwined. Clinicians are learning that within the tools of technology, there's a lot of health information. What they're frustrated with, and why the interoperability is now the buzzword, is what do you do with all the information that's in the technology if you can't access it, you can't share it, and you really can't use it. So that's where you're really on the cutting edge in these organizations of looking at bridging from just having technology put in place, which is very expensive, requires extensive hardware, software training, retraining. Workflow or workforce redesign is another terminology that so many of you will probably get introduced to. And then you have all the information management systems. I actually have another internship that I oversee at George Mason University, and it's a group of seniors that are learning how to manage the clinical information. So they are going to be clinical information specialists. So they will work side by side, hopefully in the future, with those of you in medicine, but their job is going to be running the projects to get that information out and answer the questions that you as clinicians want to see answered out of the information. So there are new fields evolving all the time. Clinical information management is a very big companion piece to the IT. So the vocabulary alone that you will pick up in this fellowship is really overwhelming. So with the few minutes left, let's go over the handout in the packet so that you can actually go to the web just like I did and download a number of these things, but also educate yourself. On the left side is just the fact sheet that tells you a little bit more about the HIMSS organization. And again, this is the largest umbrella organization that encompasses as many different groups involved in the health information technology, health information management space, including engineers. I mean, if you really get back to the origins of HIMSS, they're really the engineers who help talk about workflow, workforce, how people really functioned in an organization such as a hospital. So engineering is even part of the health information technology world. The other is the application, and there are student memberships, and I can talk to NMF about how easy it is to get students involved because you'll learn a lot online. We also have a capital area HIMSS chapter here, where if it works out with your schedule, you could be invited to attend the meetings. At least all of us go. They have wonderful panels, and you can learn an awful lot more. And also, it may be an opportunity to talk to the chapter about the fellows presenting, what they've been doing.
Well, not only that, as a member, a lot of our committees, roundtables, and special interest groups do their meeting by WebEx. So
Right, you can learn.
you don't necessarily have to be present. You can just dial in, and it's always a learning opportunity to be part of those discussions, and you add your insights.
Since you are all about health IT and the underserved, the first document I'm giving you is a paper that was actually originally drafted by one of the interns in our health policy office, and then Anna Gard, who worked on the ACU staff, the Association of Clinicians for the Underserved, edited the piece for National Health IT Week last year. And this was a handout, and it'll give you sort of a broad brush overview of resources and the content, starting from the High Tech Act all the way through to the various websites that you want to become familiar with when you're looking for resources specific to the needs of the underserved. And for those interested in rural, there's actually some rural tools, there are various toolboxes. And I would hope at a minimum, and I've talked about this even with Natasha, in those hours when you're trying to accrue your hours and you're looking for resources, come back to these paper sources and just Google them and put it in, and you will be amazed at how much you can find to help you with your projects. But you may also find professionals and others like Luis and Arno and myself who are here to help you with projects. Our students in the HIMSS and the Institute get connected to all kinds of HIMSS members to do projects, so hopefully that can happen as well. The second one, which is extremely important for those of you who are interested in health IT in the underserved and ambulatory setting, are the HIMSS Davies Award. This is recognition. These are the community awards. They give them at ambulatory and hospital, but I selected the resources for the recipients. And there's one right here, and we keep trying to get the students into Unity Healthcare because they are a Davies Award winner. But there's one in New York. The most recent one is a series of health centers in Florida. But what I want to point out to you is the importance of reading the case studies. What really happened in these sites that gave them the success using the tools of technology. And I point that out because the Unity one won because of them documenting their first failure in the implementation of a system and what really happened. And I think as young clinicians and you talk to other physicians, some of the greatest failures in IT implementation is what? Have you heard already what the greatest failure is in IT implementation? Anybody have an answer? Questioning human beings, what they want the system to do for them. You get a water bottle. There you go. Him's water bottle. But you'll see that that is the greatest failure. If you read any case studies, one of the presidents of ACU, Dr. Q. Ree, was at Cedars-Sinai Hospital as a resident. They implemented one of the first major academic systems. They all refused to use it because they were never invited at the table. The CFO, the CEO, the chief information officer, they went out and they bought a vendor, product, implemented all. Physicians were never invited to be part of the implementation process. Their response was, not my system. So hopefully we're past some of that, but I don't think so. So go through the case studies. They're very worthwhile. They're all very different in terms of how the challenges of the community and the issues of underserved populations need to be addressed when you're spending money, some of which you brought up, the government money, some of it private sector money, but also the fact that we have an incredible job to educate vendors on how different it is to take care of people for whom English may not be their first language, trust of electronics, access to electronics, all of that. But the idea that the survey says doesn't mean they don't want to be part of it. You just have to meet them where they are and train and educate them.
Is it
Okay.
appropriate for me to ask a question?
Sure.
You said,
If you do, you get a water bottle. There you go. Yes.
you said, it's important for vendors to know, what patient population they're dealing with, and obviously it's going to vary from place to place.
Mhm.
But it seems like the vendors have to keep a standardized, pretty rigid standardized system, so that way they can compare it, DC versus Maryland versus Virginia versus North Carolina. And so how do you deal with the rigidity of the desire to compare with other health systems?
Okay, then again, you will learn, hopefully there'll be some other orientations from the Office of the National Coordinator, but my second handout for you takes you to the Meaningful Use Program. And there are federal advisory committees in both health policy and in standards. And within that, these people address your question. We were very fortunate to have a member of both ACU and the HIMSS community serve on the policy committee when it was first created. His name is Dr. Neil Kalman from the Institute for Family Health in New York. He fought very hard he was the only physician at the table. And I don't know, Dr. Johnson, if you know the story, but if you're with a bunch of vendors and other corporate people, and they say, well, why do you care about the demographics? Why do you care about what language do they speak? What is their race and ethnicity? How accurate is that data? How clean is that data? We need standards. And Dr. Kalman's answer was, if you don't ask and you don't document, you can't measure any change in disparity. So in the Meaningful Use Program, and in this page, you will see that it says, you will list, it isn't here in terms of race, ethnicity, it is part of the Meaningful Use Stage 1. But getting past that and discussions, and I'm sure for those who will be with Louise Balin, you'll learn how hard it is to look at some of the other social determinants of health. I have a physician colleague who insisted when their electronic record went in place in LA, he really wanted housing. So he worked with the vendor, but you must be at the table when the vendor is hired and ask those questions. You can modify, but in terms of making it a national standard, you're right. You have to be able to have evidence and proof that everybody can do it the same. And throughout your fellowship, those are at the Office of the National Coordinator, those who will be talking about the summit, other meetings that you go to, it isn't easy to change. The story at Georgetown that I had with students, they brought something into surgery. The surgeons were not part of their implementation either. When it was implemented, they all thought everybody was going to be thrilled. What happened was they came up with a list of other things they really wanted. By the time they talked to the vendor, they said, oh, that's fine, but it'll cost you X dollars, and it'll take you 6 to 9 months, and you go to the back of the line for restructuring what we've just given you. By 6 to 9 months down the road, those surgeons who had been so excited said, who cares? You didn't care to listen or ask us to begin with. And I think that's what you folks all need to deal with. We want you to be the excited next generation. We do have a gap here in terms of generation of clinicians. You have no choice. Technology is part of how you're being educated. But speak up and ask questions about how it's being used. How will special populations be considered? You can find a lot of that through the HIT.gov website. Information technology and interoperability. This is a full hour, 2-hour conversation. But there's at least a brief here that sort of gives you an overview of what is interoperability. It really requires that physicians, other health professionals, other systems of care, psychosocial services, mental health services, dental services, eventually we're all part of a network where I as a patient can rely on the fact that if I have one record and there's information in it, there's a way for that information from one visit to get to somebody who needs that information in another visit. You will see all that. Esther and I, partially.
Maybe.
I belong to Kaiser Healthcare, so a lot of that is part of my life right now. But even the regional offices of Kaiser can't necessarily exchange everything. But I've had a patient portal, which brings me to the other biggest buzzword, and we don't have enough time for you to define it, but this talks about 5 models of patient engagement. That is the next big thing. If we can't engage all of you as patients, as well as all of you as clinicians, then we failed. So you will see some of the most important elements here, and this is another whole section of HIMSS, and there is it's called the HIMSS Connected Patient Initiative and Opportunities. And the head of this is in our office in Washington. So if any of you are working on patient engagement and connectivity, there are wonderful resources. But within the patient engagement area, we really feel that the benefit of patient engagement is going to be better clinical outcome, improved population health outcomes, increased transparency and efficiency, empowered individuals, and more robust data. If you learn anything about the policy side of this, being in Washington, no one ever has enough data to tell the story or prove the point. And when it comes to health disparities, I have a student now who's struggling to write the policy side of reducing health disparities. We must demand that data be collected. We must demand that reports be written and that we account for the dollars that are being set aside to look at disparity work. And only through our Center for Health Disparity and Disparity Research at NIH do we see some of this. The collaborative dollars that we keep referring to, they came from the Center for Health Disparity and Disparity Research for us to begin to look at the unique differences of underserved populations. So there are models here that you can go through. As I said, the initiative. And the last one I didn't give you a page on, which somebody touched on, and that is privacy and security. We give an entire 2-hour overview of the issues of privacy and security to our health policy students. And it starts with the questions about you folks are going to be using smartphones, you folks have laptops, you folks are delivering care in all different ways. The ways that breaches can occur, all kinds of ways for information to get into the hands of other people. Our specialist, Lisa Gallagher, who's now gone on to be a VP in other areas, she used to give examples to the students about, people walking into restaurants and getting calls and not realizing that their conversations actually could be overheard, and sharing information by phone. It can happen to all of you. You're all going to be very mobile clinicians, but you have to be well versed and well trained on how to protect yourselves legally, but also how to protect your patient with how you accept information and how you share information. So that's a lot in the 10 minutes, but I felt if we just gave you resources, and you can answer a few questions if there's still time. So anybody else have questions?
There's another aspect of this that I would like to bring up, being a researcher, and that is what we call big data.
Right. Yeah, we didn't bring up the whole big data.
And the fact that using computing models now, linking practices, linking clinics. I've even seen one project that was linking over 800,000 Medicaid recipients in one state. And if you want to look at how people are responding to a medication, to be able to go into that database and actually do your research on that database is a whole new way of getting information. Right. And it's something that's building right now in the research community to the point where even basic scientists can use it to do things like predict models of new medications.
Right.
So that's just one other aspect of IT I wanted to bring up.
Within the big data element, there is a Gary Puckrin who has done some incredible work with the National Minority Forum that addresses a lot of those issues. But within the fact sheet that I gave you on the best practices on patient engagement is the big term that I know ACU spends a lot of time on, and that is the whole patient literacy and health literacy. When you are a patient now, you have to sign your consent to be part of, in some cases, a big data pool. Some systems are set up that you have to opt out or you already are in. There's a lot of skepticism, and I don't know if it'll be talked about at the summit that Luis Balin's talking about. But as you know, there are a lot of people that are leery about being put into big data sets. So those are areas too that we need to look at special populations. We need to look at how they're protected and their reasons. And we talked about this a lot for the Health IT Collaborative for the Underserved, that when you talk about consent forms, explaining information, how it's going to be shared, there's a literacy level to that. And there's also the opportunity to see how much is being translated. You can't assume because someone speaks another language, they read another language. I mean, you get into the weeds in all of this. And so, again, you talk about where are the standards? How are the vendors going to help you with all of this? There's actually a physician named Dr. Lee. Lee is last name. His company is Polyglot. He actually had a grant from the National Center for Minority Health and Health Disparities Research. And he started with the whole medication issue and the fact that without addressing medication errors, you weren't going to really reduce cost or reduce hospital admissions. And so he has translated into 42 different languages using a software technology package, how to use medication, how to identify various medications, all of that. Again, that's part of the technology that you will be looking at. It's not just an electronic record. It's like, where are those tools that can make you deliver care more efficiently, more safely, more engagingly, and multiculturally.
Thank you so much, Kathy, and thank you, Arnold, and thank you for the wise questions from all of you. I think you're embarking on an amazing journey to learn a lot and to really be looking at how all of this comes together for what the one goal is to improve access to quality health care for all in our society. And you have an opportunity to look at it through different lenses with some experts who really will be able to open up some fresh kinds of ideas for you. But one of the things that I want to encourage you to do is to really take advantage of the advisory committee and touch back with them as you have questions and to explore some of the resources that Kathy has provided for you. But as you understand, fellowships also have requirements. And you've all spoken with our program manager, Jeanette Carter. I want to thank her for us pulling together this program. It's a brand new effort for ours. You are indeed pioneers in this, and we hope through your good efforts that it will be renewed for next year. So I'm going to turn the program over to Jeanette and let her finish it and tell you what you need to do to get your checks.
Thanks, Esther. So this is the most important part. What do you have to do for us to get paid, right? So you guys have all accepted the coursework into Canvas, and through Canvas there's an option for files, and that's where we'll be uploading resources for you guys throughout the course of the program. That's also where you have all of your award documents. So some of you guys have already received your first payment. In order to get that, we need to have your letter of agreement, that's your contract with us, as well as your pledge to NMF. submission of a photograph, and that is something that we actually do use when we publish. We put you guys in newsletters. We highlight you guys in during our galas. We highlight our students, and so it's something that will be published. So if you don't like your photo, you can go ahead and resubmit it. We love selfies, but it's something that is going to go to a broad audience, so feel free to put a new one in. Disbursement form, we can issue checks both electronically as well as via check, and then verification of your medical school enrollment. So at the end of the program deliverables, you're going to be required to do a health project, which you guys are doing the time that you're there, and then the things that we do throughout the program are kind of to prepare you and give you resources to be able to complete this project. We ask for a written report. It's nothing super intense. It's 5 to 10 pages. So we want a summary of what you've done. We don't want a play-by-play of every time you go into the office. From that, you should be able to produce a presentation that's 6 to 10 slides. We'll have a end of the program event, and that's where you will present. So you use this presentation for that. In addition, we also host an online library we're putting together of all of our fellows and their projects. So your PowerPoint will actually be online and available to the public. At the culminating event, we also will have a poster session. So you should be able to use your presentation to create your poster. We asked for the first draft to come in on April 15th. We'll work with you and give you feedback on it, and then the final will be due on May 1st. As I mentioned, we'll have a program culmination event. We haven't solidified the date yet, but we're looking at the end of May, beginning of June, where all 11 fellows who've been selected will present together on their projects. So we ask for monthly updates, and these will be submitted via Canvas. It's basically a paragraph. You can do it in Word format, you can do it in Excel, whatever's easier for you. We want to know how often you're working on your project, if you're going into the site or if you're not going into the site, if your mentor is accessible to you, how your project is coming along, any personal reflections. Has this project, has something happened, we have an aha moment, or has it changed your perspective in terms of how you see yourself giving care? It's also a chance for you to let us know if you need additional resources. If your mentor's given you an assignment and you accepted it, but you're not really sure how to tackle it, and you need more resources. We can't help you unless we know that that's happening. So this is a chance for you to be able to tell us that those things are happening. The distance curriculum, it's 3 components. So once a month, in the middle of the month, we will provide you with resources via Canvas to allow you to give you some background about what's going to happen, and then we'll have a webinar with a guest speaker for about an hour to talk about these 3 topics. And these are the tentative dates for the distance curriculum. Now your independent project. I mentioned that the first draft will be due April 15th and the final will be due May 1st. We ask that you organize it with headings and subheadings. It should not exceed 10 pages, and is including the appendix as well as your footnotes. It'd be great if it was standardized, so it's all Times New Roman 12 font, so that we do compile them and they all look similar. And then if you're working on a project where you do have access to people or you're doing surveys, any direct quotes that you get from people, if you're able to take photographs and use them, include those in your project. So generally our papers, we ask students to use these 5 headings. Introduction, so what is the issue that you're addressing and how large is it, who does it affect? The methodology is the population that you're working with, and then a full description of how you plan to tackle this issue. The findings would be the hard data that you get. The conclusion is, what does that data actually mean? And then your impressions of the project and the intervention. And then discussions, recommendations. So what are the next steps? How is this useful? What's going to happen? Is this just something that you guys did, or how does it actually affect the general population? As I mentioned, if you use those headings for your paper, it should be pretty easy for you to take the key components and pull them into a PowerPoint. Those would be your headings for your PowerPoint. We ask that the PowerPoint does not exceed 7 slides. Because during the culminating event, you guys will all present. And so there's going to be 11 of you, and you guys each present for 5 minutes. You guys are already at an hour if you don't go over and no one asks any questions. So think about that.
A lot of sitting.
And these will be due at the same time as the final paper. And then the poster. So the poster, you should be able to use the same headings that you use for your PowerPoint to pull into a poster, which is basically one large slide. Like I mentioned, we'll be paying for the printing and everything for that, so you just need to provide the slide electronically. You upload it through Canvas. And you will get a template that has the logos on it and everything that you need to use. This is an example from one of our other programs of a poster that was presented. Also, within your folders, there's a jump drive in there, and so all of the materials that I'm giving you and resources are available on the jump drive. In addition to that, we also have resources of other projects in the past and how they've looked. So you have examples of other posters, PowerPoints, as well as papers. So we do want to hear about what you guys are doing. In some of your organizations, you will be attending other conferences, you will be going on site visits and shadowing, talking to different providers. And so we want to know what you're doing. And if you're able to, we'd like for you guys to tweet as well as follow us on Facebook. If you have photos of yourself in action, we like to publicize our scholars at all times. So we're on Facebook as well as on Twitter, and our handle is NMF online. We won't follow you, so don't worry about us stalking you. But if you're doing something that is relative to the fellowship, you can hashtag NMF Scholar so we can find you. We definitely would love to like retweet you and stuff. And then the culminating event will be at the end of May, beginning of June, and this will be an event where everyone will present. And then we'll have a discussion similar to what we've had earlier. And so we ask that you just be respectful of everyone, pay attention, and be engaging. And remember that it's okay to disagree, because actually a lot of your organizations kind of work together, and so you'll be working on the same project from different perspectives. So it'll be really interesting to hear you guys talk and really explain like your experiences and be able to see how things in terms of interoperability, how they work together. So this would be a great time for you guys to really see like the larger picture after you finish your project. And then you also are required to do program evaluation. Required. So next week you guys will be getting a link to a pre-program survey. Your site mentors will also be asked to complete a survey, and this is just your expectations of the program. And then following the culminating event, you'll receive a link as well for the post-program survey, and your site will have to do it as well. And your mentor is required to complete the survey in order for you to get your final payment. So after you complete the culminating event, you're not done until we get the surveys to see how you've felt about the program and just to get feedback. And it helps us in arranging the program for future fellows as well. So congratulations again on being awarded the Primary Care Fellows Program. As I mentioned, we will be sharing your reports online through our resource library. It also goes to your site, so not just to your own site that you're working at, but we will share it with other sites as well, especially if your projects are related. It goes to our program sponsor as well as to our alumni.
So I want to just kind of thank Jeanette and know that you all are in good hands with all the advisory. I want to talk to you a little bit about unintended consequences. So you're going to be learning a great deal, and you're looking at this from the perspective of learning and how that's really going to inform your career. But you're in partnership with your sites, and in many cases, what you do is as valuable to the site as it is to you. And there are many things that you can leave behind in many ways that you can contribute. So it's a true partnership, and it needs to kind of be approached that way, not just as a class, but also as a partnership. And I want to leave you with one example from another program. One of our partners for our GE NMF Primary Care Leadership Program is Altamid, which is in California. And we had two fellows, it's a summer program, from the David Geffen School, and they conducted an evaluation of Altamid's patient portal. And it was from it was a bilingual portal, and it was from both the provider and the patient perspective. And Altamid valued what these students did in their 200 hours if they had to hire a vendor to do it at $500,000. Mm-hmm. So I want you to think about, as you do your projects, how valuable you're learning, but the kinds of contributions that you can make to your partners who are willing to host you. And these are all on the website. You can look at some others. There's other examples. I know Jeanette has picked out some really appropriate ones for your jump drive. But think about the unintended consequences and what you can do as you can contribute to the field, as well as what you can do to learn. closing remarks, guys? Questions from
Do you
you?
have any questions about the requirements or about HIT in general, expectations for the program? No?
You know, there'll be a number of meetings in DC too that hopefully we will keep you informed of depending
Mhm.
upon your medical school schedule. But the Office of the National Coordinator has their big annual meeting coming up. And Louise talked about one. There's also meetings on patient engagement where tools of technology are demonstrated and all. So depending on where you are in your education and training, whether you can plead to be, students in a learning mode that would like admission to some of these meetings.
Oh, volunteer?
Or volunteer. I mean, a lot of them, if the students volunteer. We also, I don't know, can you talk a little bit about our Hill Luncheon Series? Because that's something that is going to happen at least probably 2 or 3.
Actually, we
Times.
are February 4th at the Rayburn building. We are having an event on telehealth and remote monitoring. So it's Rayburn in the basement, 340, 339, 338, because we're having some tabletop demonstration. And so welcome to attend that event. And we'll be having programs like that throughout the year. The Institute, that's the main goal is the educational and research arm of HIMSS. And so our main goal is to go on the Hill and have events to talk about different health IT issues and topics.
Each one of your sites and your preceptors, in many cases, have already participated in Hill events like this. And they're the real world that HIMSS and the Institute bring to members of Congress and their staff to really give the best examples and best practices. And right now we have a large number of new Hill staff that are going to be learning just like you are, and they aren't any older than you are, about the importance of health IT. So that's what Natasha's going to be doing for us, and working with our special caucuses to really begin to bridge the relationship between HIMSS as a national authority on health IT and the caucuses that really want to see our health equality improved.